Well, good afternoon, everyone, and thank you so much for the honor of being here today to speak with you. It's really a privilege for me, and I'm hoping to share some insights from early morning here in the United States. It is still dark outside, about 5:30 a.m. So today I'll be talking about some novel treatment options for resistant gram-negative infections. Here are my disclosures. So I want to begin today by kind of setting the stage with what we have learned in recent years about the priority pathogens, or the antibiotic-resistant bacteria we should be most concerned about as clinicians. Just less than 2 weeks ago, the World Health Organization released this list of priority pathogens globally. And you'll recognize certain pathogens on here, such as carbapenem-resistant Acinetobacter or Enterobacteriales in the critical group. But I'm going to focus on a very important pathogen today in this high-risk group, and that being Pseudomonas aeruginosa. We know that Pseudomonas is highly unique in terms of all the pathogens on this list because it certainly has a significant impact on our most vulnerable patient populations, specifically those that are critically ill, have cystic fibrosis, or maybe are burn patients. But Pseudomonas is also very unique because it has a number of adaptive factors that allow it to survive in hospital environments for a great period of time. It also allows the organism to adapt based on its virulence to infect vulnerable hosts. But more specifically, in terms of antibiotic resistance, we worry about Pseudomonas because of its multi-drug resistance. We see multi-drug resistant rates ranging anywhere from 15 to 30% in the United States and in Europe and in the Kingdom, of course, and rates could be even higher in certain parts of the world. Now, even more concerningly, we've recently identified high-risk clones of Pseudomonas aeruginosa that not only have all of these intrinsic mechanisms of resistance, but they've also acquired new mechanisms of resistance, and specifically beta-lactamases. So this really is then the model organism for antibiotic resistance. Now, fortunately for us as clinicians, we have a number of new antibiotics that have been recently developed in the last several years that have given us new options to treat this very resistant pathogen. And so I'm going to focus then on, you see a number of the antibiotic resistant priority pathogens listed here, but in the red box, I'm going to focus on Pseudomonas aeruginosa. And across the top, you'll see many of these new antibiotics that have been recently developed, such as ceftolozane tazobactam or ceftazidime avibactam and imipenem relebactam, which we're going to talk about today. Now, on this graph, you'll also see that many of these new antibiotics have preserved in vitro activity against multi-drug resistant Pseudomonas aeruginosa, again, giving us more treatment options than we've had several years previously. Even more importantly now, we have some recent guidance from centers like IDSA or ESCMID that have given us some insights on how we should best use these new antibiotics. So if we turn, for example, to the IDSA guidance for difficult to treat Pseudomonas aeruginosa, what they suggest is that one of 3 antibiotics should be used as a preferred option. Those 3 preferred antibiotics are ceftolozane tazobactam, ceftazidime avibactam, and imipenem relebactam. Now, importantly, the IDSA recommends to use these antibiotics as monotherapy, typically not in combination with other antibiotics. They don't recommend nebulized antibiotics, but they also note that there's a certain risk for the emergence of further resistance to these new antibiotics. So many of us in the field then are reading all of this information and consuming all of it, but I think we're all left with the same question. How are we going to pick which of these antibiotics might be best for our individual patient? Well, my goal today is to try to walk through a roadmap of how you might make some of these decisions at your local institution. For instance, it's important that we all have some understanding of the baseline mechanisms of resistance in Pseudomonas aeruginosa and how those mechanisms of resistance might impact your local hospital or your local epidemiology. Something I'm very passionate about is now real-world evidence. How are we using these antibiotics against critically ill patients in our hospitals, and how well do they perform? Are patients responding in an appropriate manner? And then finally today, I'm going to walk through a patient case where I think the patient history and prior antibiotic exposures were really informative for how we selected the next treatment options for individual patients. So let me begin by showing you a fairly complicated slide that I assure you I will simplify during the course of this lecture. When we talk about Pseudomonas aeruginosa and beta-lactam resistance, there's really three predominant mechanisms of resistance to keep in mind. The first of which is beta-lactamases. There are a number of different types of beta-lactamase enzymes, and in general, many of these new antibiotics have preserved activity against beta-lactamase producing Pseudomonas, as you can see represented by the green check marks here. Pseudomonas aeruginosa also produces a chromosomally encoded or intrinsic cephalosporinase known as PDC, or Pseudomonas-derived cephalosporinase. And this cephalosporinase can be de-repressed, meaning that the organism makes more beta-lactamase, and of course that leads to more resistance for the organism that we see. Secondly is membrane permeability. Many of our antibiotics, like the carbapenems, for example, need to gain access inside the cell through outer membrane porin channels, and specifically in Pseudomonas, the one porin channel we watch very carefully is known as OPRD. This seems to be the highway for which carbapenems get inside the cell, and mutations in this pathway close off that highway so the carbapenems are no longer able to get inside the cell. And then finally is antibiotic efflux. If our molecules can get inside the cell, there are constitutively expressed or chromosomally encoded efflux pumps that recognize those antibiotic molecules and pump them back out of the cell. So these three mechanisms of Pseudomonas are all very important, but concerningly, they can all occur in tandem, meaning that organisms may have beta-lactamases and overproduce efflux or shut off their porin channels all in concert. So none of these mechanisms tend to exist by themselves. They all coexist with other mechanisms, meaning that selection of the appropriate antibiotic therapy is then dependent upon antibiotics that overcome multiple mechanisms of resistance. And so what this looks like then, if we start to compare and contrast some of our new treatment options, let's start with ceftolozane tazobactam versus ceftazidime avibactam. Now, many of you in the audience will recognize these antibiotics as ones you've perhaps used in your clinical practice. And they're both based on cephalosporin molecules as a backbone. Starting with ceftolozane, ceftolozane is unique because it is basically the same molecule as ceftazidime, except it has a unique R2 side chain substitution that you see circled in red here. This substitution is very important because it overcomes multiple mechanisms of resistance in Pseudomonas that we just talked about. It increases the molecule's stability against beta-lactamases like AMP-C. It increases affinity for the target site, the penicillin binding proteins, and it makes the molecule less likely to be effluxed back out of the cell. Now, in comparison, ceftazidime, or the backbone of ceftazidime avibactam, we know the resistance in Pseudomonas is mainly driven by increased expression of AMP-C and increased expression of efflux. Those mechanisms of resistance are very important for why we would then add different beta-lactamase inhibitors. So tazobactam, when you add it to ceftolozane, really doesn't help Pseudomonas at all because ceftolozane itself is already stable against many mechanisms of resistance. On the other hand, adding avibactam to ceftazidime helps overcome one predominant mechanism of resistance, and that's AMP-C beta-lactamases. Avibactam is a good beta-lactamase inhibitor, a diazobicyclooctane beta-lactamase inhibitor that inhibits AMP-Cs very well. So you can overcome one of the two main mechanisms of ceftazidime resistance. But because ceftolozane overcomes multiple mechanisms of resistance, what we see in vitro data is that the MICs are generally lower for ceftolozane tazobactam because of those multiple mechanisms of resistance it overcomes. For example, here, if the MIC 50 and 90 for ceftazidime are 16 and greater than 32 respectively, we generally see in surveillance studies ceftolozane tazobactam median MICs are around 1, whereas the ceftazidime avibactam MICs are about 4-fold higher, around 4, because again, avibactam is only overcoming one of those mechanisms of resistance. Now we have other options, of course. We also have now carbapenem-based beta-lactam, beta-lactamase inhibitor combinations like meropenem, vaborbactam, and imipenem, relebactam. Again, let me briefly contrast these two molecules for you because you may be thinking in your clinical practice when you're going to pick one over the other. And I know imipenem, relebactam is now newly introduced into the kingdom. So when might you be thinking about using it? Well, let's start with the two carbapenems, because in Pseudomonas aeruginosa, the underlying mechanisms of resistance for meropenem and imipenem are actually different. For meropenem, we know resistance is mediated by loss of those outer membrane porin channels, OPRD, but also meropenem is effluxed out of the cell. The efflux pump is known as MEX-AB-OPRM that recognizes meropenem and extrudes it out of the cell. But notably, you'll see here that meropenem is not liable against AMP-C beta-lactamases. That is different for imipenem. The main mechanisms of resistance for imipenem are also loss of those porin channels, but now increased expression of AMP-C beta-lactamases, which can hydrolyze imipenem. These underlying mechanisms of resistance are important because when you add a beta-lactamase inhibitor like vaborbactam to meropenem, you see no change in the MIC. The reason for this, again, is meropenem resistance is mediated by porin channels and efflux, but not beta-lactamases. Thus, the meropenem MIC50 for both meropenem and meropenem vaborbactam is largely the same. In contrast to that, imipenem is hydrolyzed by AMP-C beta-lactamases. And so when we add an inhibitor like relebactam, a beta-lactamase inhibitor, you see the MICs drop significantly. Here, for example, the MIC50 for imipenem is around 8. When you add relebactam, that MIC50 comes down to 1. So largely an 8-fold reduction because you're inhibiting AMP-C hydrolysis. So the next step then is if we understand the core structures and how they may overcome some common mechanisms of resistance, what we want to know is across surveillance studies, how active are these various antibiotics and how can we compare and contrast them? Well, we're starting to get some very good surveillance data from a number of networks across the globe. I'm showing you here data from the SMART Surveillance Network that was conducted in between 2016 and 2021 across 266 laboratories in 61 countries. What you can see here is that rates of susceptibility for both imipenem, relebactam, and ceftolozane tazobactam are very, very high. In fact, I've circled here the Middle East region where both of these antibiotics have in vitro susceptibility rates greater than 90% for Pseudomonas aeruginosa. But what might cause some of the resistance at baseline? Well, when you take it a step further and you look at the underlying mechanisms of resistance for those isolates that were resistant, what you find in the Middle East region specifically is the production of metallo-beta-lactamases. Now, none of the beta-lactam, beta-lactamase inhibitors we've talked about thus far today have activity against metallo-beta-lactamases. So these are very, very important to recognize in your region. And if they are common in your region, it may be a reason to look for alternative therapy. Now, how common metallo-beta-lactamases are by region varies across the globe significantly. For example, where I practice in the United States, you can see here in this data from the ARLG, the presence of metallo-beta-lactamases is very, very low, about 2% against all carbapenem-resistant Pseudomonas that were studied from the United States. In contrast, if we look at the Middle East region, we see that metallo-beta-lactamases are a bit more common. For instance, in this study, VIM, a common metallo-beta-lactamase, was identified in 18% of carbapenem-resistant Pseudomonas, as well as GES enzymes and another 8% of isolates. So there are ongoing circulation of metallo-beta-lactamases in Pseudomonas, which is something that we need to work with our microbiology colleagues to be able to identify. Now, if you look specifically within the various regions across the kingdom, what you'll see is that the presence of metallo-beta-lactamases varies by region. In general, here I'm showing you a study where 22% of all isolates were resistant to both meropenem and imipenem. A lot of this resistance was explained by porin loss and efflux, as we had talked about. but 18.8% of these isolates did harbor carbapenemases, and the most common carbapenemase identified in this particular study was GES enzymes, followed secondly by VIM. So very important for us as clinicians to be able to recognize metallo-beta-lactamases and Pseudomonas and know how that may impact our local rates of susceptibility. So next, what we want to know is how can we compare all three of the first-line recommended antibiotics? Well, the SMART surveillance system has also given us some very important information along this line. I'm now showing you data again from the United States here because it paints a very important picture. In a region such as mine, where carbapenemases are very rare in Pseudomonas, we could compare and contrast each of the three recommended antibiotics for MDR or difficult to treat Pseudomonas. And what you see from this figure is that ceftolozane tazobactam generally retains the highest rate of susceptibility, around 78.3%, compared to 65.6 or 55.5% for ceftazidime avibactam or imipenem relebactam specifically. But at the very bottom of your screen, against difficult to treat Pseudomonas or DTR, these are the most resistant strains that this study could find. You see again even higher rates of ceftolozane tazobactam activity compared to the other two antibiotics. Now, these kinds of data are important, but you want to know how these kinds of data might impact your local regions. So I couldn't find great data in Saudi Arabia specifically, so I wanted to show you some data from Europe that might similarly represent your local epidemiology. So here again, you see ceftolozane tazobactam MICs in green, ceftazidime avibactam MICs in blue, and like we talked about, the MICs for ceftolozane tazobactam always tend to be lower because, again, it's overcoming multiple mechanisms of resistance. But when you look across each individual country, you'll see that the rates of susceptibility are generally very close to each other or similar in terms of rates of susceptibility, with some exceptions. For example, Portugal here is a notable exception where ceftazidime avibactam had higher rates of susceptibility than ceftolozane tazobactam. Might there be an underlying mechanistic reason for that? Well, of course, the answer is yes. In Portugal, we see much more GES carbapenemases than really any other region across Europe. And you see here that this production of GES really driven that difference in ceftazidime avibactam versus ceftolozane tazobactam. So now that we know a little bit about the in vitro activity of these antibiotics and underlying mechanisms of resistance, let's talk about some clinical data. And I'm going to first think about, well, between ceftazidime avibactam and ceftolozane tazobactam, how are you going to pick which of these two agents to use at your hospital for patients with resistant Pseudomonas? Well, if you look at the randomized clinical trials that have been conducted for these two antibiotics, what you'll see is they've both been compared to meropenem in randomized clinical trials, and both were identified as non-inferior to treatment with meropenem. However, what's notable from this slide is that very few patients with multi-drug resistant Pseudomonas were enrolled in these clinical trials. So really, we don't have a great baseline to know where one agent might be better than another. So what we need to use then is real-world observational data. And fortunately for us, a very talented group of infectious diseases pharmacists in Saudi Arabia have put together one of the first studies comparing ceftolozane tazobactam to ceftazidime avibactam for multi-drug resistant Pseudomonas. This was done across 6 centers in the kingdom, and they identified patients who were treated with either of these two antibiotics for at least 48 hours because of infection due to multi-drug resistant Pseudomonas. And they identified clinical cure as resolution of the infection with really a need to modify the existing antibiotic regimen because of toxicity or clinical worsening. And what they found is that in general, clinical cure rates and in-hospital mortality rates were similar across 100 patients that either received ceftolozane tazobactam or ceftazidime avibactam. And you see here similar rates of recurrence and acute kidney injury as well. So from these data, I pose the question, can we conclude then that these two antibiotics are equally effective? Well, I'm not so sure, and let me tell you why. I think there are some important limitations with any observational data. For example, the epidemiology in the kingdom may preferentially favor ceftazidime avibactam in certain regions where guest carbophenamases are common. And typically, we would identify that by doing susceptibility testing against isolates. Unfortunately, in this study, less than half of the isolates were tested against either of these two antibiotics. And among those that were tested, there tended to be higher MICs for patients that receive ceftolozane tazobactam. So this may shift the balance in terms of comparative effectiveness. Secondly, we know that antibiotic dosing in this study also tended to favor ceftazidime avibactam. In fact, 20% of patients who received ceftolozane tazobactam received what we now know to be a suboptimal dose for resistant Pseudomonas. And many of those patients who received a suboptimal dose ended up failing treatment. Moreover, polymicrobial infections and combination therapy were more common in ceftolozane tazobactam treated patients. Both of those factors generally indicate sicker patients with more ongoing critical illness that again could shift our comparative effectiveness balance, as is the case with mixed infections. And in this study, all infection types were included. So patients, for example, that might have urinary tract infections could then be compared to patients that have bloodstream infections or pneumonia. So this is a very important study and starts to give us some initial clues, but I don't think is the definitive answer that these two antibiotics are equally effective quite yet. And the reason that I bring this up is this is one of the reasons that we conducted what we call the CACTUS study, or a multi-center comparison of ceftolozane tazobactam and ceftazidime avibactam in the United States. Now, importantly, differentiating this study from what I just told you is we only included patients that had multi-drug resistant Pseudomonas aeruginosa, pneumonia, or bloodstream infections. Those are the only two infection types included. We also matched patients 1-to-1. So every patient that received ceftolozane tazobactam was matched to a patient that received ceftazidime avibactam at the study site. And we matched patients by 3 factors that we know mediate outcomes: severity of illness, infection type, and time to treatment initiation. And so we powered this study to enroll 420 patients total with the outgoing hypothesis that treatment with ceftolozane tazobactam would be better because of its in vitro properties that we've talked about earlier in this lecture. And so what I first want to show you is how well matched these two groups were. We were able to enroll 210 matched pairs, or 420 patients total. And you can see here across all the severity of illness markers that we looked at, including SOFA score, severe sepsis or septic shock, residence in the ICU, patients were very well matched and nearly identical in both treatment groups. Also importantly, this was a very critically ill patient population that we enrolled in this study. 80% of patients were in the ICU at the time treatment was initiated, and 70% of patients were receiving mechanical ventilation at the time study drug was started. So this represents then many of the sick patients we see in our hospitals that are in the ICU with severe pneumonia. So what did we find? Well, here's the top level findings. We found that clinical success was more commonly achieved for patients who received ceftolozane tazobactam compared to ceftazidime avibactam. Not only did we match patients in this study, but we performed conditional logistic regression analyses to control for any potential imbalances that we didn't find by just matching alone. And that's what led to the odds ratio of a 1.97 better odds of clinical success with ceftolozane tazobactam. Now, we are also very interested in patients with pneumonia specifically. And in fact, this was 350 of the total patients. And you see among the pneumonia subgroup alone, the rates of clinical success were even greater with ceftolozane tazobactam compared to ceftazidime avibactam. Here now the adjusted odds ratio is 2.17. You'll also appreciate from this slide that recurrent infections were more common following treatment with ceftazidime avibactam. And in fact, that's what really drove the differences in clinical outcomes in this study is patients treated with ceftazidime avibactam who had recurrent pneumonia after treatment. Okay, so finally then, let me conclude with a couple of slides about how you might take some of these factors with a patient history into account in appropriate antibiotic selection. And so this is a patient that we took care of at my hospital several years ago. It was a 55-year-old woman with non-ischemic cardiomyopathy and had a left ventricular device, assist device in place. And she had recurrent bloodstream infections due to multi-drug resistant Pseudomonas. You see the susceptibilities here. It was already a resistant strain that we treated with meropenem. We quickly selected for meropenem resistance, and then she received a 2-week course of ceftolozane tazobactam. And unfortunately, what happened next is we identified a ceftolozane tazobactam resistant Pseudomonas isolate after exposure. And this raised a number of clinical questions for us. For example, what would be the mechanism of ceftolozane tazobactam resistance? But also, why did we see cross resistance to ceftazidime avibactam? And what might be the reason then for seeing different changes in susceptibility with, say, piperacillin tazobactam, which became more susceptible? And what might be a treatment option for a case like this? So we ended up studying a number of patients like this, and we took 23 patients and took their isolates before and after treatment with ceftolozane tazobactam. And you can see across all patients, the median duration of exposure was 20 days. And what we found is we did whole genome sequencing to look at underlying mechanisms of resistance. And what we found is what was causing resistance to ceftolozane tazobactam was mutations in this AMP-C beta-lactamase that we talked about. And here you can see a stepwise increase in the MICs for both ceftolozane tazobactam and ceftazidime avibactam. And so we found resistance was driven by these AMP-C mutations. But what was equally surprising and important is if you go to the far right-hand side of this slide, we saw at the same time that resistance developed to ceftolozane tazobactam, imipenem became more susceptible. And in fact, this was true in this individual patient example, and it was true across all of the patients that we studied. In fact, 79% of ceftolozane tazobactam resistant isolates were then susceptible to imipenem and imipenem relebactam. And the reason for that is that AMP-C mutation caused a structural modification that allowed imipenem to become more active or have collateral susceptibility. So this is a very important mechanism that causes resistance to one antibiotic, but increased susceptibility to another antibiotic that might give us a new treatment option. And in fact, when you look at the underlying enzyme kinetics, what you find is that those modified AMP-C beta-lactamases do indeed hydrolyze both ceftolozane and ceftazidime very, very well. But they lose their ability to hydrolyze imipenem, which explained the phenotype that we were seeing clinically. And in fact, similar observations have been made from Spain among patients who developed resistance to ceftolozane tazobactam. All of those isolates became susceptible to imipenem relebactam. And we also see this in surveillance studies, where again, ceftolozane tazobactam non-susceptible isolates have the highest probability of being susceptible to imipenem relebactam compared to other agents. So this
Ryan,
underlying
1 minute left.
Okay, thank you. I'm on my last slide. Okay, so let me conclude with a lot of information and say that defining mechanisms of resistance in Pseudomonas aeruginosa is very complex. Ideally, you are able to have multiple therapeutic options available to you, and your microbiology laboratory can test all of these options and tell you which is most active at your local institution. It's very, very important that at your institution, you know these rates of susceptibility. At my institution and in many other parts of the world where carbapenemase enzymes are not present, ceftolozane tazobactam does tend to be the preferred agent. And when we see resistance evolve to ceftolozane tazobactam, it's very important to know that cross-resistance to ceftazidime avibactam happens, but so too does collateral sensitivity to imipenem relebactam, and that might be an important therapeutic option for you. Finally, we've seen from comparative effectiveness data, we're starting to get some clues on how these antibiotics all compare against each other, And I think that's going to be very important as we move forward to select the best antibiotics for our patient. So thank you again so much for your time and attention today. And it's been a privilege to speak with you here early morning in the United States. Thank you very much.